Good morning. I'm Michael Green. I'm one of the infectious disease doctors at this hospital, as you know. And it is really a treat for me today to introduce our speaker, Dr. Anne Rowley. I met Anne Rowley in 1983 when I was an intern, and she was one of my second-year residents here, well, actually in Oakland at the Children's Hospital of Pittsburgh. And we've remained friends and colleagues for that long period of time. And I'm excited to tell you a little bit about Anne before she gives us her talk. So Anne is a pediatric infectious disease clinician scientist, and she is recognized truly worldwide for her work and expertise in the field of Kawasaki's. Anne has leveraged looking at immunologic and pathologic response to Kawasaki's disease to really ask and maybe will answer the question, maybe she'll tell us she's answered it already, what causes it? What agent actually causes this disease? Anne's training is she got her medical degree at SUNY Upstate, and then she came here, as I mentioned, to do her residency. She left her residency and went to what was at the time Children's Memorial Hospital in Chicago, where she did her fellowship, research fellowship at Northwestern, and stayed on. And she is professor of pediatrics and of microbiology and immunology at the Northwestern University Feinberg School of Medicine. And she's an attending in the Division of Infectious Disease at the Lurie's Children's Hospital. She's been, her expertise has been leveraged and used by a lot of different organizations. She served on the board of the Pediatric Infectious Disease Society, the American Board of Pediatrics Subboard of Pediatric Infectious Disease, the American Heart Association's Committee on Rheumatic Fever, Endocarditis, and Kawasaki's disease. She's been funded by lots of different organizations, including the NIH. I want to include her last sentence in what she gave, things that she enjoys doing when she's not working. I'm reversing the order. She knows I'm doing it. Mostly she loves taking care of her now 6 grandchildren. She likes to bake, and particularly one of her grandsons likes her, you think you said muffin, so she has to bake them every week. She reads, she gardens, and spends time with her family, and looks at her husband, who's now retired, while she continues to work. It is a true delight for me to introduce Anne Rowley to you all, and I'm excited to hear this talk. Thank you.
Thank you very much, Mike. It's really a pleasure and an honor to be here. I can tell you Mike was as energetic back then as he is now, so that has not changed. So I am going to actually give my presentation as a pre-recorded video. I really appreciate everybody's putting up with that. I have some issues with my voice, so I cannot give an hour lecture anymore. So we're going to go ahead and get that started, and then I'm going to come up at the end and we'll put up my slides, and then if there's any questions on a particular slide, we can go back and look at it.
Good morning. It is great to be back in Pittsburgh, where I trained in pediatrics quite some time ago, and I very much appreciate the invitation to speak to you at Grand Rounds today about Kawasaki disease, including some clinical and research controversies. I appreciate the opportunity to record this presentation because I am having some difficulties with my voice. I'm happy to answer questions in person following the presentation. These are my disclosures. The physical findings in patients with Kawasaki disease are shown in the left panels. Classic diagnostic criteria include fever for 5 days, with 4 of 5 of the other features: bulbar conjunctival injection, red dry cracked lips and strawberry tongue, red swollen hands and feet, rash, and cervical adenopathy. These clinical features can be observed in non-KD infectious and inflammatory conditions of childhood, although cracked bleeding lips and red swollen hands and feet are more specific for KD than some of the other findings. Recognition of a prolonged fever illness as KD is important because of the potential complications that can arise, which include coronary artery aneurysms, which when severe can either thrombose, leading to myocardial infarction or rupture, leading to sudden death. Rupture generally occurs in the first month after onset, but myocardial infarction can occur as a later complication. This can result from thrombosis of an aneurysm and also from stenosis, from obliteration of the lumen due to proliferation of modified smooth muscle cells. The reason for this phenomenon is not understood, but it pathologically resembles coronary artery stenosis that occurs in heart transplant patients. Patients with giant aneurysms and coronary artery Z-scores above 10 are at greatest risk of complications, with those patients who have coronary artery Z-scores above 20 at particularly high risk. The Z-score is essentially a standard deviation, so that a child with a coronary artery Z-score of 10 or 20 has a coronary artery that is 10 or 20 times larger than the average child of the same height and weight. On this slide is also a cardiac catheterization image showing how large the coronary aneurysms can be, and an autopsied heart showing coronary artery aneurysms with diameters larger than the aorta and the pulmonary artery. If the diagnosis of KD is missed or delayed, and if the coronary artery size is not carefully monitored in the first 2 to 3 weeks after fever onset in those in whom the diagnosis is made, a fatal result can ensue. Similar to many other childhood conditions, not all patients have all features of the disease at presentation, and it was recognized decades ago that some children, particularly infants, developed coronary artery aneurysms following a febrile illness that did not fulfill classic diagnostic criteria. The term incomplete KD is preferred to atypical KD because this entity refers to the lack of full diagnostic criteria and does not mean that these patients have clinical features not normally seen in KD. This algorithm provides guidance in making the diagnosis. It is recommended that children with prolonged fever and 2 or 3 other KD clinical features undergo evaluation. And it also recommends that infants with prolonged unexplained fever, even without KD clinical features, undergo evaluation. The initial recommended laboratory evaluation is a CRP and sedimentation rate. If neither of these are elevated, KD is unlikely. If they are elevated, then a 2-tiered evaluation is recommended, consisting of a set of laboratory tests and an echocardiogram. If neither of these are of concern, then it is recommended to serially evaluate the patient. If there are 3 or more abnormal lab findings or a positive echocardiogram, defined as either a coronary artery Z-score of the right coronary artery or left anterior descending coronary artery of 2.5 or higher, or the presence of at least 3 of the following: mitral regurgitation, pericardial effusion, myocardial dysfunction, and coronary artery Z-scores of 2 to 2.5. I would like to point out a couple of features of KD that may be underappreciated. First, KD is a disorder of young children, but it is important to recognize that the peak age is in late infancy. These are epidemiologic data from Japan, but the same is true for the US and other countries. It is important to have a very high index of suspicion for KD in febrile infants, especially because they may often have incomplete presentations. Second, it is important to recognize that the prevalence of aneurysms is highest in infants, with 48% less than 1 year developing aneurysms compared with 25% in older children, and boys at higher risk than girls. These data are for IVIG-treated patients. You may think this sounds like a high prevalence of aneurysms in both age groups, and many of us quote a reduction in aneurysm prevalence with IVIG treatment from 25% to 4% to parents based on multi-center trials of IVIG carried out long ago. But it's important to recognize that those studies were using older criteria for diagnosing aneurysm. Using z-scores corrected for body surface area, the prevalence of coronary aneurysms in KD is much higher than was previously recognized and is particularly high in infants. Some situations in which a KD diagnosis has been missed are depicted here. Even at my institution, which is fairly attuned to diagnosing KD, all of these scenarios of missed KD diagnosis have occurred. Aseptic meningitis in an infant without detection of a virus in the CSF should prompt consideration of a KD diagnosis. Shock as a presentation of KD is rare, but can occur. More common are the last three scenarios. Retropharyngeal phlegmon, unresponsive to antibiotic therapy, should prompt consideration of KD. And in those situations, there can be other features of KD present, but not initially noted. Pyuria leading to antibiotic treatment, followed by rash attributed to antibiotic allergy, is a fairly common scenario for missed KD. The detection of group A streptococcus in the throat in febrile children is appropriately first managed with antibiotic therapy. But if the patient fails to respond, KD should be considered because the patient may be a strep carrier. Most notably, KD diagnosis is not excluded by detection of a respiratory virus. If the patient has clinical features compatible with KD, serious consideration should be given to the diagnosis despite detection of RSV, influenza, or another respiratory virus. KD is most common in the winter-spring when respiratory viral infection is very common. Some clinical features of KD are rare in respiratory viral infection and may help make the diagnosis, such as red, swollen hands and feet and refusal to walk, rash that is accentuated in the groin area, and cracked, bleeding lips. As part of my research, I collect autopsy tissue samples from fatal KD cases. And one of the common reasons for missed KD diagnosis among these children was that the illness was attributed to a respiratory virus detected when the patient presented for initial evaluation. I'd like to discuss a few clinical controversies in KD. Can we diagnose KD earlier? How should high-risk KD patients be defined and treated? How should patients who do not respond to IVIG be managed? And are KD and MIS-C related? So let's get to that last question first, since I think this has been resolved. Certainly the clinical features of MIS-C resemble KD, but this is also true for many other childhood illnesses. The epidemiology of these two conditions is markedly different, with a dramatic difference in the usual age group affected. KD cases decreased significantly during pandemic mitigation measures when SARS-CoV-2 infection was so common. This was true even in countries where MIS-C was rare. The targets in the heart in the two conditions are also different, with MIS-C causing myocardial dysfunction with transient mild coronary artery dilation, similar to that observed in systemic onset JIA, while KD can cause coronary artery aneurysms that can lead to significant complications and be lifelong. Most importantly, the pathologic features of MIS-C and KD are different. Studies from Japan decades ago showed that marked inflammatory cell infiltration into the walls of coronary arteries, in other words, coronary arteritis, was observed in all fatal KD cases. In autopsy studies of MIS-C to date, coronary arteritis has not been observed, and pathologic findings in the heart have been confined to the myocardium. It is important to recognize that, unfortunately, the literature is replete with potential MIS-C, KD misdiagnoses, and in particular, the rare report of cases of MIS-C with giant coronary artery aneurysms were very likely cases of KD. Fortunately, MIS-C has virtually disappeared for unclear reasons since the end of 2022, so this is no longer much of a diagnostic conundrum. The current diagnostic criteria for MIS-C could be fulfilled by patients with culture-negative sepsis, and it is presently quite difficult to diagnose MIS-C with confidence because of a lack of distinctive clinical and lab features. It would be helpful to diagnose KD earlier because very early treatment might improve outcomes and would reduce patient suffering by administering therapy earlier in the illness. The rate of coronary artery aneurysms in Japan is substantially lower than in most other countries, and it is possible that this is because they make the diagnosis earlier in most cases. However, it is difficult presently to identify a child as having KD on day 3 of fever, for example, since so many other conditions can cause fevers of that duration. Some have wondered if AI could help make the diagnosis. Presently, there are some programs that clinicians can use to help them decide if KD is the most likely diagnosis, but it is not clear yet that these are a real advance. Online AI will often suggest a diagnosis of KD with prompting of the symptoms, so this may help clinicians who are not familiar with KD. This is an area for future study. In Japan, there are good risk scoring systems that assist clinicians in determining the likelihood that a child with KD will fail to respond to IVIG therapy, but these risk scoring systems perform poorly in non-Japanese children. There are some scenarios that appear to convey increased risk of coronary artery aneurysms in children with KD regardless of their race and ethnicity. These include the presence of a coronary artery aneurysm as defined by a Z-score of 2.5 or greater at diagnosis, presentation during infancy, especially at less than 6 months of age, and presentation with shock. Because these subgroups are recognized to be at high risk even with IVIG treatment, the question as to whether adjunctive primary therapy would help these patients arose. In Japan, the so-called RAISE study was performed many years ago, in which children with high-risk KD were randomized to IVIG and aspirin alone or with corticosteroid therapy in a tapering regimen over 2 to 3 weeks. The results were quite impressive, with significantly fewer patients who received corticosteroids developing coronary artery aneurysms. This experience led many in the field to recommend adjunctive primary treatment of high-risk KD patients with a regimen of tapering corticosteroid therapy. At our center, we use corticosteroids in a RAISE regimen as the adjunctive treatment for high-risk patients. Other centers use infliximab, although there is no prospective study showing efficacy. In 2 studies, adjunctive therapy with either high-dose pulse corticosteroid or infliximab to all KD patients, not just those that are high risk, was administered without convincing evidence of efficacy. So adjunctive therapy is recommended for high-risk patients only. There is controversy over defining high risk, and each center may use somewhat different criteria. At our center, we do incorporate certain laboratory criteria in our determination of high risk, similar to some of the Japanese scoring systems, but different from other U.S. centers that may confine high-risk treatment to infants under 6 months of age and those with coronary artery aneurysms at diagnosis. It is very important that these patients have frequent echocardiograms and cardiology evaluations so that additional antiplatelet and anticoagulation therapies can be promptly initiated if aneurysms are enlarging. How to treat IVIG non-responders, those that continue to have fever 36 hours after completion of the first IVIG infusion, remains an open question. At our center, we repeat echocardiography if fever persists, and if coronary artery aneurysms are present, we treat with IVIG and corticosteroid in a tapering RAISE regimen. If no coronary dilation has developed, we give second dose IVIG only. We always reconsider the KD diagnosis. At around day 14 of fever, if the patient has not developed any coronary artery dilation, another diagnosis should be strongly considered. At other centers, a variety of other immunomodulatory therapies are used, and at our center, these are only used in those rare patients who continue to have fever, persistently elevated CRP values, or worsening coronary artery disease. It is important to recognize that KD spontaneously subsides in all cases, although it may take several weeks to do so. Therefore, determining efficacy of any of these treatments without a controlled trial that includes a substantial number of patients is very problematic. Frequent echocardiographic and cardiology assessments are critical for non-responders with coronary artery aneurysms. Let's discuss a few research controversies in KD. One theory of KD etiology is that multiple diverse infectious agents can lead to an autoimmune disease process. Another theory is that there is a single infectious agent or closely related group of agents that causes the disease but has simply not yet been identified. This is a very simple slide summarizing two theories of KD etiology and what one would predict about the epidemiology of the illness based on these two theories. I like to think of these as the host is the main problem for the theory of diverse infectious triggers, and the causative agent is the main problem for a theory of a single ubiquitous infectious agent. If diverse agents caused KD, one would expect that KD could occur at any age and that recurrence would be frequent, since infection with one triggering agent would not provide immunity to another triggering agent. Epidemics should not be a feature of the condition if many diverse agents could cause the condition, and no specific route of entry would be needed. Conversely, if there were a single ubiquitous causative agent that generally resulted in asymptomatic infection, but could cause KD in a genetically susceptible child, passive maternal antibody might prevent the illness in the first few months of life, but then cases would emerge in later infancy and young childhood and become progressively less common in older individuals who would be immune from prior asymptomatic infection. Recurrence would be rare, since adaptive immunity would be protective, and epidemics and outbreaks would be common. Most ubiquitous agents enter via mucosal surfaces. All of the features on the right are characteristic of KD, and the marked decrease in KD cases during COVID mitigation supports entry of the pathogen at a mucosal site. This slide is to emphasize that epidemics and outbreaks of KD have been commonly reported. One might then ask about evidence for person-to-person transmission of KD. How could one assess for person-to-person transmission of a ubiquitous infectious agent that causes KD if it usually results in asymptomatic infection and when there is no specific test? Presumably, one would need a highly susceptible group of children in a small population and geographic area to observe person-to-person transmission of KD. These conditions were met long ago on an island off the coast of Japan, when 9 children developed KD over a 1-month period of time. Investigation by Japanese epidemiologists revealed close geographic and social contacts among the involved families in the north of the island, where the cases began, and subsequent cases in the south following contact between families in the north and the south. During epidemics of KD in Japan, geographic spread of cases was observed, suggesting a transmissible agent. And in siblings who had the disease, there were 2 peaks of cases, one on the same day as the index case, suggesting common exposure to the agent at the same time, and one 7 days later, suggesting an incubation period of about a week with transmission from the index case to the sibling case. As I mentioned, there was a remarkable decrease in KD cases throughout the world when COVID mitigation strategies were put in place. These graphs show data from Korea and Japan, but the same patterns were observed in the US and other countries, with a marked decrease in cases during COVID mitigation strategies in Korea, as shown in red in 2020, and in Japan in blue in 2020. COVID mitigation unexpectedly provided a real-world experiment that supports a transmissible agent as the cause of KD. I'd like to summarize our immunologic and pathologic data supporting a single novel respiratory virus in the pathogenesis of KD. We identified an IgA immune response in KD coronary arteries, an unusual location for an IgA response, and made antibodies from clonally expanded immunoglobulin A heavy chains in combination with random immunoglobulin light chains. These antibodies were not precisely the antibodies that the patients were making because they lacked cognate light and heavy chain immunoglobulin pairing. However, they identified virus-like intracytoplasmic inclusion bodies in some KD cases by immunohistochemistry, which led us to perform additional studies of these inclusion bodies. These are electron microscopy images of the intracytoplasmic inclusion bodies in KD bronchial epithelium, labeled ICI, with virus-like particles labeled VLP in close proximity. The tissues had been placed in formalin, but not in paraffin, making electron microscopy possible. But the images are not as crisp as would be observed with glutaraldehyde fixation. Unfortunately, to date, no tissue fixed in this way has been available. Special light microscopy stains indicated that the inclusion bodies contained RNA, but not DNA. We theorized that if plasma cells producing antibodies targeting antigens important in KD pathogenesis were present in coronary arteries, they would also be present in peripheral blood. And when single-cell technologies became available, we began to prepare KD antibodies with correct light and heavy chain pairs from single-cell plasmablasts. This cartoon shows that when we are healthy, we have a low level of many different plasmablasts in our peripheral blood, ready to help us to respond to new pathogens that we encounter. When we develop a new infection, specific sets of plasmablasts that have a good fit for the pathogen will be clonally expanded. Following recovery, the plasmablast pool once again becomes diverse. Our experimental design was to take blood from children with KD at 1 to 2 weeks after fever onset and single-cell sort peripheral blood plasmablasts by flow cytometry into 96 well plates. We then amplified the light and heavy chain immunoglobulin genes from each plasmablast to identify clonally related plasmablasts and produce KD monoclonal antibodies. We performed these studies on blood from 12 children with acute KD who presented during different seasons and across many years. We sequenced 15 plasmablasts from these patients and so far have made about 100 monoclonal antibodies. Using human proteome screening, we did not identify a human protein as the target of KD antibodies. Using peptide arrays, we identified a sequence recognized by several KD monoclonal antibodies, and we further refined this sequence using amino acid substitution arrays, yielding a peptide sequence that additional KD antibodies recognized. This sequence does not match to any known microbial or human sequence. Immunohistochemistry showed that these new monoclonal antibodies also identified the inclusion bodies in KD bronchial epithelium, with stronger binding and less background compared to our earlier versions that lacked the correct light and heavy chain immunoglobulin partners. Of the antibodies we have made to date, 43% react with the single peptide epitope, and 57% identify inclusion bodies in KD tissues. 33% do both. At least one antibody from each of the 12 patients recognizes the inclusion bodies, and at least one antibody from each patient recognizes the epitope. Inclusion bodies are rarely observed in infant controls, including those with RSV and influenza. Antibodies that recognize the inclusion bodies but do not bind the peptide presumably bind to another epitope of the etiologic agent. Very notably, a single monoclonal antibody from an acute KD patient identifies the inclusion bodies in all of 20 acute KD fatalities from diverse geographic regions of the US and Japan and across 5 decades, supporting one predominant causative agent of the disease. Here are immunohistochemistry images of bronchial epithelium of 10 children with KD who died in the US within a month after fever onset, all of which have spherical brown staining inclusion bodies indicated with arrows in some of the panels. Here are similar images of tissues from 10 children from Japan who died within a month after fever onset, demonstrating the same spherical brown staining intracytoplasmic inclusion bodies. We did not observe the inclusion bodies in 19 infant controls who died of a variety of non-KD conditions, and example images are shown in panels A through I. Typical brown spherical inclusion bodies were found in one infant control with dilated cardiomyopathy of unknown cause, as shown in panel J with arrows. Epidemiologic and pathologic data from our studies and those of others have suggested that the KD agent may cause persistent infection in at least a subset of children. This has led us to theorize a model of transmission of the KD agent, shown here. During COVID mitigation, respiratory viruses that do not cause persistent infection, such as RSV and influenza, almost disappeared, as shown here on the left. In contrast, the prevalence of roseola, caused by a virus that results in persistent infection and is generally transmitted from previously infected individuals in the home, did not change during COVID mitigation, as shown here on the right. KD, shown in the center, decreased significantly, but less than RSV or influenza, and infant cases decreased less than cases in older children. This is compatible with a virus that can be transmitted either from an acutely infected asymptomatic child or from a persistently infected parent or sibling in the home. These two possible modes of transmission could explain both the increased prevalence of KD during winter-spring from Route A transmission and cases from other seasons from Route B transmission. We propose that the KD agent can be acquired either from an acutely infected child with mild or no symptoms, or from a persistently infected asymptomatic individual in the home. The genetically predisposed child develops KD. The etiologic agent infects bronchial epithelium and is picked up by macrophages that take the pathogen to other sites, including the coronary arteries. The immune system clears the pathogen, except that it can remain hidden in inclusion bodies in bronchial epithelium, which can periodically reactivate and result in shedding and transmission. We are presently assessing whether a B-cell ELISpot assay can be used to detect plasmablasts recognizing the KD peptide in a timely fashion to determine if this could serve as a diagnostic test for the disease. It has been difficult to identify the causative agent in children with acute KD at the time of clinical presentation. The pathogen may be present in greatest quantity before symptom onset, as is true for many viral illnesses. The primary sites of infection are inaccessible to the researcher, hampering efforts to identify the pathogen. We have begun a project to sequence respiratory samples from family members of children with KD over time to identify a new persistent infectious agent that might be shed intermittently. Here are some important takeaway points. It is important to diagnose and treat KD to avoid potentially long-term cardiac sequelae as much as possible. Clinicians should have a high index of suspicion for KD when evaluating children with prolonged, unexplained fever, particularly infants, because they are the most likely to have incomplete clinical presentations and the most likely to develop coronary artery disease. Adjunctive primary therapy for high-risk patients should be strongly considered. Optimal treatment for IVIG non-responders remains unclear. Epidemiologic, pathologic, and immunologic data support a ubiquitous infectious agent that forms inclusion bodies in bronchial epithelial cells as the cause. I would like to acknowledge my collaborators on the research work, which has required teamwork and persistence. Thank you for your attention, and I'd be happy to answer any questions.